My name is Stefano Fazzini. I'm Associate Professor and Consultant of Vascular Surgery from Tor Vergata University in Rome. The presence of calcium remains a major challenge in the endovascular treatment of calcified iliac artery disease, affecting both procedural and long-term outcomes. We all know that primary stenting is the standard of care, but there are some issues with stenting, such as the stent recoil, the stent under expansion, or procedural complications such as iliac rupture. So we know that we don't have an ideal stent in calcified iliac treatment, because sometimes we need the balloon expandable in the common, self-expandable in the external, and probably we should avoid to cover key branches such as hypogastric artery, and we should avoid the unnecessary kissy stent. Another point is avoiding the transition zone, such as high flexible points in the distal segment between the external and the common femoral artery. In case of severely calcified iliac lesion, Shockwave IVL as a first-line strategy allows for avoidance unnecessary stenting or optimizing stent expansion, both of which contributes to favorable midterm outcomes. The IVLIAC study is a multi-center registry with the aim to evaluate the midterm outcomes of patients with calcified iliac artery disease treated with IVL, with or without stenting, and to propose a new algorithm guiding these different treatment strategies. This is an algorithm based on the lesion type, stenosis versus chronic total occlusion, and the intraoperative functional assessment, EVUS, so the so-called extravascular ultrasound, and gradient pressure, to determine whether stenting is necessary. We all know that sonic pressure waves increase the luminal gain and the vessel compliance, but such modifications are not always well visible on angiogram. For this reason, these methods play a crucial role in determining whether IVL standalone therapy is enough. For example, with the angiogram and the high-grade residual stenosis or for limited dissection, so with some complication, of course, we do a stent. But in case of no complication and a good assessment, by triphasic waveform in place of monophasic with EVUS, or no more gradient pressure, we could do IVL standalone therapy. A total of 100 calcified iliac lesions were treated in 86 patients with the IVL standalone therapy in 77% of the cases, and with IVL plus stent, so with adjunctive stenting, in the remaining 23% of the cases. At 2 years follow-up, we had a primary and assisted primary patency of 95 and 98% respectively, with a secondary patency of 100%. In the first example, we have a bilateral common iliac occlusion, so we plan to use a stent. In this case, we use IVL as a vessel prep, a single catheter, 5 cycles per each side, and then a stent afterwards. In this case, we have a right common iliac stenosis, tight stenosis at proximal segment of the common iliac, and probably we should need a bilateral scaffolding above the aortic bifurcation. In this lady, we did the angiogram after the IVL treatment with 10 cycles, and then no gradient pressure, triphasic waveform on table, and for this reason we decided to use IVL standalone therapy, no stenting, and you can see the triphasic flow 1 year later with the bilateral tibial pulses.